Hello everyone, my name's Nadia Rosen. I'm the CEO of Head and Neck Cancer Australia, and I'd like to welcome you today to the second of our Head and Neck Cancer Outreach webinars on hearing during and after treatment for head and neck cancer. We're really pleased to be able to bring you today's webinar on World Head and Neck Cancer Day. I must admit we've had a flurry of activity this morning, sharing posts on head and neck cancer and doing some radio interviews that will be broadcast across the country, really focusing on early detection and ensuring that people are aware of the signs and symptoms of head and neck cancer so they can get diagnosed early. So that's our key message this World Head and Neck Cancer Day. We're very grateful to the Western and Central Integrated Cancer Service in Melbourne, who very kindly funded the webinars that we're hosting this year. And I'm really pleased to introduce our host for today, Julie McCrossin. Julie is a radio broadcaster and journalist. She's also a former head and neck cancer patient and a passionate advocate for people living with head and neck cancer. Julie's going to host the webinar today. So over to you, Julie. Thank you.
Thanks heaps, Nadia, and welcome everybody to World Head and Neck Cancer Day. It's odd to say we celebrate it. Obviously, head and neck cancer is a tough gig, but I do say we're celebrating because Head and Neck Cancer Australia, who are hosting this webinar series, are doing so much to inform patients and their families and multidisciplinary team members and to improve the care that we receive. So welcome, and I'd like to acknowledge that I'm on the land of the Kaurna people. I'm coming to you from Adelaide, as our special speaker will be this morning. I'd like to acknowledge elders past and present and emerging, and just pay recognition to this culture that has survived so well for so long. And of course, Aboriginal and Torres Strait Islander people are disproportionately affected by head and neck cancer. Now, we are interactive today. So we're going to hear from a senior audiologist. We're going to hear all about hearing and what we can do to improve our hearing and manage the impact of treatment. And we really welcome your questions. If you see down the bottom, there's a Q&A button. If you click on that, please put your questions in. I'll be coming on 2 or 3 occasions during our session back to Nadia Rosen, and she'll be sharing questions with our speakers. And I also want to say to you, though, we can't obviously go into detailed individual cases. We can give general information on topics. But if there is something that's troubling you, obviously your first port of call is your own clinical team, but you can also ring 13 11 20. 13 11 20. That's the Cancer Council information and support line, 13 11 20. We're recording our webinar today, and it will be posted on the Head and Neck Cancer Australia website and all their social media that Nadia has already mentioned. And if you're not on social media, get on social media to spread the word about head and neck cancer. Even if you don't want to post your own things, you can retweet or post on LinkedIn or on Facebook the marvellous posts of Head and Neck Cancer Australia. We'll send you a survey at the end so you can give us frank feedback, and we'll take it all into account for our next webinar in this series, which will be in September. So let me mention, before I introduce our first speaker and we kick off, let me mention that up the back, if you could wave Tracey, we can see Tracey Nicholls, who's an ear, nose and throat and ENT nurse practitioner and the South Australian coordinator for head and neck cancer. Tracey will be available to us later at the end of our session. If you've got any questions that are relevant to her expertise, she'll be popping in, as well as Holland, who I'll introduce in a moment. And Tracey has been the president for 11 years of an ENT nurses group. I think they're called otolaryngology nurses group, and it's a terribly bad sign if you can pronounce that word. I am, of course, a head and neck cancer survivor myself. But Tracey has travelled to the United States and to the United Kingdom, visiting other cancer centres, and she started a patient group in South Australia in 2016. So we'll look forward to your comments later. But now let's begin. And I'm absolutely thrilled to introduce Kathleen Holland, also known as Kathy, a senior clinical audiologist for over 35 years, initially in the United States and Kathy has worked in Australia since 1990. She's the coordinator of the public program at Flinders Medical Centre in Adelaide, with a great particular interest in hospital-based audiology, cochlear implants, I think in adults, and the assessment of complex patients. And we're all really looking forward to hearing and learning about our hearing. So deaf sign welcome clapping to you, Kathy, and we'll come back with questions later.
Thank you, Julie. I'll just take a moment to share my screen. So it's very exciting to be asked to speak to you all today, and to really highlight hearing and the importance of hearing. So it's great to be here to talk to you all. As Julie said, there will be plenty of time for questions and answers, and I'm going to be speaking about hearing, about chemotherapy, radiotherapy, and what we do to monitor hearing. In between the different sections, we'll pause and allow some time for questions to come through. So if it looks like your question might be answered in a slide coming up, those questions might be held, but we'll try to get to as much of the questioning as possible. We've got a mix of professionals and patients who've signed up today, so I'll try and address things so that we're gearing it to everybody. And we'll start by looking at the ear. So there are three main parts to the ear. So you've got the outer ear, which is the ear canal, the pinna, and the ear canal, which leads up to the middle ear, which is comprised of the eardrum and the three small bones in the middle ear, the malleus, incus, and stapes, or hammer, anvil, and stirrup, as it's commonly referred to. The middle ear needs to have air because it's sealed off by the ear canal, by the eardrum, and there's a channel that runs from the middle part of the ear down to the back of the throat, and that's the eustachian tube. So that is what you pop and clear when you're going up and down a hill or up in a plane, and that keeps the ear working optimally. The bones then connect to the cochlea or the inner part of the ear. So hearing loss can be affected by problems in any one of these areas, the outer ear, the middle ear, or in the inner part of the ear. So there are three main types of hearing loss. So sensory neural hearing loss, sometimes people call it nerve damage. It's not necessarily the nerve itself, but it's the inner part of the ear. Unfortunately, hearing loss in the inner part of the ear or in the cochlea generally tends to be a permanent hearing loss. Then we have what we call a conductive hearing loss, and a conductive hearing loss can be a result of problems in the outer or the middle part of the ear. So if the ear canal is full of wax, if you've got a hole in the eardrum, if the eustachian tube isn't working properly, and the eardrum, what happens over time is the air inside behind the eardrum gets used up and the eardrum starts getting pulled in, and ultimately that can result with the ear filling up with fluid, and that can cause hearing problems. So those types of problems, wax, eardrum, middle part of the ear, often those can be treated. So those are often temporary conditions. They might resolve over time or improve with treatment. Then we have mixed hearing losses. So that's a combination of the inner ear, sensory neural hearing loss, and the conductive hearing loss. So some people are unlucky enough to have a bit of both. Now I'm going to look at the cochlea a little bit further. So the cochlea, or the inner part of the ear. So the cochlea is arranged, and as you move through the cochlea, it's arranged tonotopically, or by pitch. So at the entrance of the cochlea, that's where we have the really high pitch sounds. And then as you move in through the cochlea, as it spirals around, you're moving up to low pitch sounds. So when we assess hearing, we want to look at how well you're hearing at all of those different pitches. And on here, it's equating it to the piano with 500 hertz, or this low pitch down here. So all of this area is represented here, and then the low pitches are here, deep in the cochlea. And how we measure hearing and plot the results of a hearing test is represented on an audiogram. And I think it's good if you have a bit of an understanding of an audiogram. We'll often see patients that come in and they've had lots of hearing tests, but they don't have any understanding of what the results mean. So this graph here, as you look across on an audiogram, pitch is represented. So we're going from low pitch sounds out to high pitch sounds, and soft sounds down to very loud sounds. So we plot on here what's the softest sound that you can hear for each pitch. Now, when we plot the results, it looks a bit like this. So on this graph, the X's are representing the left ear, the O's are representing the right ear. So if you look at the X's, all of those X's are at 20 or above. So on the side, the loudness we measure in decibels. And if all of the responses are 20 and higher, or lower in terms of number, higher on the picture, but lower in terms of intensity, that signifies normal hearing. So when you have normal hearing, you can hear sounds at a very soft level. And then on this graph, you'll notice all these different speech sounds represented. If you've got normal hearing, you can clearly hear the low pitch sounds, which are often the vowel sounds and some of the consonant sounds. And you can also hear the really soft consonant sounds, such as an S, a T, an F. Those sounds tend to be air sounds. So there's not a lot, there's not voicing, there's not the loudness to those sounds. So you've got softer and higher pitched. And what happens, so if you look at the right ear, what this is showing is that this person could hear low pitch sounds normally, or at the borderline of normal levels. But as the pitch gets higher and higher, we have to make the sound louder and louder and louder for them to hear those sounds. And when you have a hearing loss like that, what happens is you can still hear people talking. You're getting the loudness, and you're getting those low pitch sounds, you're getting the vowel sounds, but you're missing a lot of the consonant sounds. So when that happens, that's when people say, everybody's mumbling, I can't hear clearly, I don't have a problem hearing, it's just that other people don't speak properly. So That's what the high frequency hearing loss tends to do. So hopefully that gives you a little bit of an understanding what the audiogram looks like, what we're measuring. There are other tests that we might do when you have a hearing test. So we do a test called bone conduction testing. If you've ever had your hearing tested before, some of the testing is done with headphones on, and then some of the testing is done with a little thing that sits behind your ear. What that does is it sends the sound directly to the inner part of the ear, or the cochlea. So if you have a conductive hearing loss, which is that temporary problem. So if your ear is full of wax and blocked, or you've got fluid sitting behind the eardrum, when we have the headphones on, we have to make things quite loud for you to hear because it has to travel through the whole system. When you have the bone conductor behind the ear, then the sound is going straight to the cochlea or the inner ear. It doesn't have to go through the wax and through the fluid. So by testing bone conduction, that helps us to pinpoint what type of a hearing loss is it. Is it a conductive hearing loss? Is it an inner ear hearing loss? So that's really important for us to know. We do another test called tympanometry. That's a test where we put a little probe up to the ear. We take a measurement. It feels a bit like when you're going up and down a hill or in a plane. You feel that little bit of pressure. That helps us to see, is there a problem behind the eardrum? Is there a pressure problem? Is there fluid sitting behind the eardrum? Is it blocked with wax? There's another test called otoacoustic emissions. That's a test that we sometimes do. We tend to do it more with young adults who have really good hearing. That can be another piece of the puzzle. Anybody, as we get older, those emissions diminish, even if we have reasonable hearing. And if you have a hearing loss, we tend to lose those responses. So that test would be particularly useful if we were monitoring children undergoing treatment who wouldn't always be able to give us a response. That would be an objective way of looking at hearing. So you may or may not have a test like that done. The other thing that we can sometimes look at is looking at speech discrimination, or doing a test to see when speech is presented and words are presented, how clear is that? Can you understand the words clearly, or are you missing parts of the words? So that's another test that we might do. You won't necessarily have all of those tests every time. Depending on the equipment that is available, different tests might be used. So that's just a bit of basics behind how we test hearing and what we're looking at. So I'll throw back to you, Julie and Nadia, and see if anybody has any questions, or if you have any questions about how we test hearing.
Look, thank you so much, Kathy. We've got a lot of questions coming in. They're mainly relating to the later part of your presentation, but I guess I would like to ask, for anyone who's watching this who's a very new patient, what's a critical message? And is one critical message that it's important to get a hearing test as soon as possible, so that there's a baseline measure available in case you have future hearing loss? Could you explain my question and then give me an answer?
Yes, yeah, we definitely will be looking at that later, but a baseline test is really important, because if you don't have a test done before you start treatment, and sometimes there are factors that make that really difficult, and again, we'll talk a little bit about that. But if we don't have a baseline, and then you come to me or the doctors refer and say, oh, can you check this person's hearing? They're having problems hearing. We want to know if their hearing has changed. Well, I don't know if it's changed, because if we don't have something to compare it to, we can't tell how much it's changed. And sometimes if you're starting off with a hearing loss already, what can happen is that even a small change can have a big impact. So even though you're feeling like the hearing has changed a lot, it may or may not have. So that's where it's really tricky without a baseline, because maybe you had some hearing loss, maybe it was in those high frequencies, and you were coping, it had come on gradually, you hadn't noticed it. All of a sudden, you get a little bit more hearing loss, it spreads a bit more to different pitches, and then you think, oh, that's really putting me over the edge. So that's why the baseline is really important.
Well, let's continue your... Oh, sorry.
Sorry, Julie. I might do, as Julie said, most of the questions do relate to later in your speech, but I thought I'd just throw one in myself, because people often say that they haven't been told to get a baseline hearing test before they start treatment. So what's your advice to people if, again, they're new to, just being diagnosed and it doesn't get raised by their team? What would you suggest that they do?
Well, speak to your team, speak to the team, see what's available. Different hospitals, different programs are going to have different levels of testing available. I think we're really fortunate here at Flinders. I mean, I'm really proud of the program we have, and think that what we're doing is very much best practice in terms of baseline and monitoring, but there are a lot of factors that determine whether people are referred or not. But yeah, you could look to going to a private clinic if there isn't something available readily. But the first thing would be to speak to your team.
Great. Well, let's continue with the presentation.
All right, so we're going to look next at what is an ototoxic drug, how do chemotherapy and radiotherapy affect hearing. So there are two groups of drugs that are known to be ototoxic, two main groups, and those are chemotherapy drugs and some of the aminoglycoside antibiotics such as gentamicin. Oto refers to the ear, and toxic refers to something that is poisonous. So an ototoxic medication literally can be known to affect hearing. So it doesn't mean that it will, but it can. As it says, there are over 200 medications known to be ototoxic that may affect your hearing and or your balance system. I didn't really point out, but in the earlier slide looking at the ear, if you notice the inner ear or the cochlea also had some little circular bits coming off it. So it looks like a snail, but had the little circular bits. Those are the semicircular canals, or the what controls your balance. So it can affect the balance system as well. And things that can damage the ear can also cause tinnitus or ringing in the ear as well. So some of the common chemotherapy drugs that are potentially ototoxic, and two that we see most often, are cisplatin and carboplatin. So cisplatin is very widely used for a lot of head and neck squamous cell carcinomas. Probably many of you receive treatment with cisplatin. Carboplatin is the other one. There's also oxaliplatin, which isn't as toxic as these two. Cisplatin is the one that has the highest incidence of affecting hearing. So there are there are varying reports and varying studies looking at the incidence of hearing loss and tinnitus. Some of this may be hearing changes that people haven't noticed. Also, it's important to know it's not generally that it causes you to completely lose your hearing. It can have subtle effects on hearing. So the range of estimates is 30 to 80% for cisplatin, and that may affect your balance as well. Carboplatin, as you can see, has a much lower incidence of effects on hearing or tinnitus, and it's also less likely to affect balance. With chemotherapy, the effects tend to be more immediate. If it's going to affect your hearing, it tends to have its effect during the treatment. Maybe not the first treatment, maybe not the second treatment, but it can build over time. So usually it's the very high-pitched sounds that are affected first. On the audiogram that I showed you earlier, it showed you a range of pitches that we test. We have special equipment that actually allows us to test much higher. The human ear can hear, I think actually a future slide looks a little bit more at this, but we test out to really high frequencies to look for change before you might even notice change, and before it has the ability to affect your understanding of speech. So how does chemotherapy affect hearing? Cancer drugs usually work by disrupting cell replication. So it's targeting cells and trying to get rid of the bad stuff. But unfortunately, it can also damage healthy cells as well, which is the case if it affects your hearing. It can destroy the tiny little hair cells in the cochlea that receive sound and send it off to the hearing nerve. So you might ask, well, why are you going to treat me with a drug that can have these effects? And sometimes there is little choice. So cisplatin is known to be the best thing to target many cancers. So that's why the doctors will choose that drug. And I know people have asked, well, what are the things, what affects the risk for hearing loss? And there are a lot of different factors that affect that. And your doctors are constantly having to weigh up the risks of the treatment and the benefits of the treatment. And so by juggling dosages and number of treatments and how they administer the treatment, those things can sometimes be controlled, can sometimes be altered. Combination of chemotherapy as well as radiotherapy to the head and neck, which again, that generally is something that has to be done in a lot of cases, but that also increases risk. Some factors are not controllable, such as your age, other health issues such as renal failure, things that are preventing the body from clearing the drugs from the system can contribute to the toxins building up in the ear. And noise exposure during treatment, that is certainly something that can be controlled and something that we ask people about. A lot of times people aren't working during their treatment, but if you are doing some work, if you like to do things around the house and you're feeling well and you're using power tools, those things you really have to be extra careful. We know that noise exposure can cause hearing loss, and we know that some of these drugs can cause hearing loss, but when you put them together, then you're increasing that risk further. So that is definitely something that you can control. Radiotherapy, on the other hand, that can cause both temporary changes and permanent changes to hearing. So if the radiotherapy is directed towards the middle part of the ear or the ear itself, or directed towards the back of the throat, that can affect the eustachian tube. Okay, so that's that tube that runs down to the back of your throat and allows you to pop and clear the ears. So if the radiotherapy and swelling in the throat affects the functioning of that, then there can be problems with the middle part of the ear. So you can end up with a negative pressure behind the eardrum, or you can end up with fluid behind the eardrum. The tricky thing with that is oftentimes the doctors don't want to do what's often a common treatment for fluid behind the eardrum that's persisting and not clearing. Is in many cases they might put a little grommet or a tube. So often it's something you hear children getting grommets to prevent the fluid from building up behind the eardrum. But because things might be particularly fragile because of the radiotherapy and the other treatments, they don't want to do that. So sometimes people have that fluid sitting there for a while, and then the hope is that once the treatment stops and the swelling might improve, that will resolve. But that can be something that people have to deal with for a while. The other thing with radiotherapy, unlike chemotherapy, where'd my pointer go? Whereas the effects from chemotherapy tend to occur more immediately while you're undergoing the treatment, the effects from radiotherapy might not show up for up to 3 to 5 years post-treatment. So at Flinders, we monitor hearing for 3 years after radiotherapy. But those changes are more gradual and you might not notice them straight away. So I'll throw back to you, Julie and Nadia, and see if we've got any questions.
Look, thank you so much, Kathy. As a former patient treated in 2013, I must say I'm learning a lot about why I'm having hearing problems, but I just wanted to welcome people who've joined us since we started. And Kathy Holland is a senior audiologist at Flinders Medical Centre in Adelaide, and we're in the midst of a presentation on all aspects of hearing. And the CEO of Head and Neck Cancer Australia, Nadia Rosen, is monitoring our questions. Over to you, Nadia.
Thanks. So Kathy, I might ask a few because they're all kind of related. So one person, Peter, asked, does the data show that hearing loss from radiation therapy and chemo is greater with older patients? Diane asked, does hearing improve when chemotherapy has finished, if it's been affected? And Angela from Queensland is 15 months post-treatment, and she wants to know, will the effects of cisplatin get worse as she ages, or is the damage that she has now, would that be considered stable? So they're a few that we've had.
Okay, so I'll go to the first one. In terms, refresh me, the first one was...
Oh, sorry, does the data show that hearing loss from radiation and chemo is greater with older patients?
Worse with older patients. Actually, some of the data show with children, the risks are higher. I think one of the things with older patients is oftentimes they're already starting off with a level of hearing loss. So as I said earlier, if you're already starting off with a hearing loss that perhaps you've been coping with, that little bit of extra change might move you from not needing a hearing aid to needing a hearing aid. So I think that's probably the biggest difference. You are at a little bit higher risk with age, and also with other other conditions in terms of your general health. So you're perhaps more apt to have other conditions that might also contribute to you being more susceptible to change. So
and Diane, who asked, does hearing improve when chemo has finished, if it's been affected, or does it stay stable?
Unfortunately, the changes that we measure and the changes due to the chemotherapy do tend to be permanent changes. So that's why it is so important to monitor it. Keeping in mind that monitoring doesn't mean we're going to prevent the change, but we can detect it early, and potentially there might be modifications to treatment to prevent significant further change. But that's the thing with the hearing loss from the chemotherapy, is it is permanent. In terms of stability, as you get older, your hearing may change further, because that's a separate thing that's going on with the aging process. So having that change isn't going to prevent further change, but it doesn't necessarily put you at higher risk for further change either. That's where other factors like genetics, noise exposure history, all of those factors are going to come in and potentially have effects later on as you age.
Nadia, could I ask a question and then come back to you for one? Just a quick one. I'm just mindful, Kathy, I'm 8 years since treatment, and my hearing and I had cisplatin and radiation to all the areas you mentioned, because I had oropharyngeal, tonsil, tongue and throat cancer. But I was never recommended to have a baseline hearing test. But I did hear about them through my speech pathologist, because we all have contact with speech pathologists generally in our multidisciplinary teams, because we have trouble with swallowing. And so I'm very mindful that if it deteriorates over time, most of us have no contact with our multidisciplinary team after 5 years. So this is my question, the role of the general practitioner. What I've discovered is that most GPs have very limited knowledge of head and neck cancer or the associated side effects, because they see so few in their career. And so what I've done is take the Head and Neck Cancer Australia printed materials, and I'd like to take a link to this video that's being filmed now and will be on the website to my GP, and say, can you look at this and help refer me to the necessary tests and monitoring to help me monitor this, because we can't rely on our head and neck cancer team to do it after the 5 years. And with so many of our side effects, it's after the 5 years that we really start to perhaps need the hearing aids. So just, I guess, a comment on the role of the GP.
So yeah, you can speak to your GP about a referral. Once you get to that point, you don't necessarily need specialized monitoring. That's where you would want to, if word of mouth is often the best way to determine where you might like to be referred to have a hearing test, but you could go to any clinic at this point, but talk to the GP. Does the GP have any recommendations, any clinics that he's worked with, he or she has worked with? talk to friends. Does anybody have hearing aids, and anywhere that they could recommend to go, but you don't need specialized testing. The other thing is, in Australia, we do have very good access to hearing aids for pensioners. There are gaps between age 26. We have very good access to hearing aids under age 26, or for very significant hearing losses through the NDIS. But we also have good access to people who are on a pension, have funding through the Office of Hearing Services program, or through the Hearing Services program. So there are options available. And if you don't qualify for those options, then there are private clinics available.
Thank you.
I guess that's one question that we've just had from Leanne, who's a dietitian in Tassie, Northwest Cancer Centre in Tassie, who's asked if patients have to go privately, if there's no audiologists in the public system, do you know if these costs are covered under Medicare, or is it private, through private health insurance only?
It would depend on the clinic, and I don't believe the private health insurance actually would cover the hearing test, but there might be some Medicare coverage for the hearing test itself. Yeah.
A couple of other questions, if we've still got some time, Julie.
Yeah, let's take a couple more.
Yeah, okay. Someone's asked, fluid buildup in the middle ear, does it get worse in time? Should one seek treatment for it?
Yeah, definitely seek treatment for that. So fluid behind the eardrum, that is something that we hope would be a temporary condition. So whilst you're undergoing the treatment, and there might be problems with the back of the throat and swelling and issues, then that fluid might develop, but you would definitely want to have that investigated. As I said, if you're undergoing treatment, often the doctors are reluctant to put a grommet in the eardrum, but again, that all depends on the type of treatment that you're having. So I would definitely seek an opinion on whether that's treatable.
Okay, and a patient from Sydney, Usha, said that vertigo, I'm not quite sure if this question or a statement from Puma, but a vertigo is a symptom that hearing loss could happen. Is it true that steroids can help in reducing the severity of that?
I'm not sure about steroids with vertigo. Steroid treatment is sometimes used with sudden hearing loss of unknown etiology. So if we don't know why it's occurred, sometimes steroid treatment will improve that. Whether if it's a result of undergoing chemotherapy, I don't know. That's really a medical question, but I'm not sure about that. But in terms of being a sign of potential hearing loss, I guess it's more a sign that something's going on within the inner ear. And it sounds like it is affecting the balance system. People that have long-term issues with balance, that's where physiotherapy can come in to help with retraining the brain and retraining the balance.
Well, look, Nadia, we might go back to our final segment, and then, ladies and gentlemen, we'll answer as many questions as we can after our final segment of presentation. So over to you, Kathy.
Thank you. So I'm just, we spoke about doing the hearing tests, but now I want to talk more about how do we actually monitor it for patients undergoing treatment that's potentially ototoxic. So I said before that standard hearing tests that we do, generally we test from 250 to 8,000 hertz. So that's reasonably high frequency, but the human ear can hear all the way up to 20,000 hertz. When we do monitoring for people undergoing chemotherapy, we test all the way out to 16,000. So the best way I can explain that is, if you remember, like older TVs and equipment had that really high pitch kind of a whine that would come from the electronic equipment. That kind of a sound is really high pitched, and around that 16,000 hertz mark. So we test out to those very high frequencies. They don't contribute to speech understanding necessarily, but if we're seeing changes out there, we're helping to detect change before you might notice it and before it will have an impact on speech understanding. So we do test a broader range of frequencies and pitches when we're testing for this reason. When should hearing be tested? So we spoke before about a baseline test before you start treatment. Now, that's easy to say that it should be done, but more so with the aminoglycosides and something like gentamicin, the antibiotic treatment. So we're talking about chemotherapy with antibiotics. Those often are because someone has an infection and treatment has to be started immediately. So if someone has a heart infection, they're not going to say, oh, let's wait and get a hearing test before we start treatment. So there are a lot of factors that determine how readily a baseline can be done before the treatment starts. But often with chemotherapy and radiotherapy, it is more planned and it can be done. So we often get referrals saying, about to start, can you get a hearing test done? And we definitely try to do that. Occasionally we can't, but we try and get it done as soon as possible once someone has started treatment. In terms of monitoring with chemotherapy, we like to monitor prior to each cycle. So if your cycle is 3 days in a row this week and 1 day next week, and then you get a week off, that'd be a cycle. And then we'd monitor you before you started the next one. So oftentimes the patients we see are having 3 weekly cycles. Some patients have weekly treatments, and in that case, we don't necessarily have people come in every single week for a hearing test, but we might monitor them before they start treatment, after they've had a couple treatments, at the end of the treatment, and then we monitor for 3 to 6 months, or at the 3-month and potentially the 6-month mark after treatment. If someone hasn't had any change through the course of the treatment, we might just see them once, 3 months post, and if they still haven't had any change, we say, well, it doesn't look like you've had any effect from it, so we don't need to see you again. If someone has had change during the treatment, we'd see them at 3 months and then at 6 months post-treatment. That's for chemotherapy only. For radiotherapy or radiotherapy plus chemotherapy, we monitor before they start the radiotherapy. If they're not having any chemo, then we don't have to see them during the radiotherapy treatment. We'd see them 3 months, 6 months, and then 1, 2, 3 years post-treatment. That's our protocol here at Flinders. It doesn't mean that's what everyone's going to do, but that's what we do here. What is a significant change? So it's important to recognize that there is normal variability from one test to the next, because we're looking for the softest sounds that you can hear. Those sounds are so soft that you might hear it one presentation, and then the next time you don't hear it till it's slightly louder, and then you hear it again the next time. So you get normal variability in a test, but it's only very small. So if we see a shift in hearing at any one frequency of 20 decibels or more, so that's a fair drop at one pitch, If we see a drop at 2 pitches next to each other of 10 or more, then we call those changes significant. So those are the changes that we notify the treating doctors that we have measured hearing, we have seen what we consider a significant change. Now, we notify the doctors of those change. We're not notifying them to tell them what to do for treatment, but it's to keep you informed. It's to keep you informed. It's to keep the doctors informed. It allows you to have those discussions about the treatment, whether there is anything that can be changed that might help prevent further change. It does say the hearing changes tend to be permanent, but the tinnitus or ringing in the ears, that perhaps will stop. So any decision about changing in treatment, that's something between you and the treating doctors. It's not something to decide independently. The other thing is, if we do find changes, it allows the audiologist to work with you to talk about strategies to deal with changes in hearing, or provide referrals to places that might be able to give you more support. So what can you do if you notice change in ringing? So either you didn't have any ringing before, or you may have had it before, but it's louder, it's more annoying, it's more bothersome. If you have fullness or pressure in your ears, if speech starts sounding muffled or unclear, as I said before, changes in hearing, it's not like you just lose your hearing, but things might start to sound different, start to sound muffled. If you have dizziness, all of those things should prompt you to discuss it with your treating team. What can the audiologist do? Keep you informed, provide you with strategies, refer you for a hearing aid if that's appropriate, and provide support and strategies for coping with tinnitus, which I've put in a few extra slides on that, because I know that for many people, that's the most disconcerting thing is tinnitus. So things to remember: that the ability to monitor varies between hospitals. Not everyone has an audiologist available. Even if there are audiologists available, not everyone has the specialized equipment to allow testing out to the really high frequencies that I said we monitor out to. Speak to your doctors about any concerns. Just remember that if hearing loss develops, there are options, there are things that can help. Tinnitus often reduces over time. And there are strategies that can help you cope with tinnitus. And please, please avoid loud noise whilst you're undergoing treatment. So just quickly, managing and adapting to tinnitus. So tinnitus, it's noises that you hear that other people don't hear. There's no physical sound outside. The sounds are going on inside the ears, inside the head. Some people will hear it in an ear. Some people say it's just in my head. You can adapt to it. And then in adapting to it, it's reaching a point where you don't have that reaction to the tinnitus. It is one of those things, it's very real, but the more you think about it, the more you get angry about it, the more you get annoyed with it, the worse it gets. So pain is similar. It's very real, but how you think about it, how you react to it can make it even worse. So there are strategies that you can do to help with that. So you want to identify and manage stress and other triggers, such as diet. So caffeine can be a trigger for some people, but it's about trying to identify what is it that makes that tinnitus worse. Some people find that using other sounds, having a TV on in the background, having a radio, having music can help to distract them. There are noise generators that can play some sounds in the background just to give you something else to listen to. Recognize that you don't need to fear the tinnitus. It's not that something sinister is going on inside the head. Hearing aids can help with the tinnitus. So again, that's bringing in useful sound. When people have a hearing loss and they're not getting sufficient input from the outside world, the tinnitus can worsen. Keeping busy, finding activities that you enjoy. So oftentimes when people are engaged in something and not just focusing and stressing on the tinnitus, they find, oh, actually, I'm not noticing it now. It's only when you call the attention to it again that they find that it's worsened. And finally, you might seek the help from a psychologist who can help you work through it and change how you think about the tinnitus. We all adapt to sounds around us and learn to push those sounds aside without even worrying, thinking about it. Just common everyday things. But if you're in an unfamiliar environment and new sounds come in, you can focus on them. So that's the goal with tinnitus, is find strategies to move away from it. So Nadia and Julie, are there any final questions?
Kathy, thank you so much. And that was so useful. I want to tell you, ladies and gentlemen, we're going to take 10 additional minutes. So we will go for another 10 minutes because we have a range of questions. So over to Nadia, please.
Oh, thank you. Thanks, Julie. Okay, so one person's asked, if hearing loss is identified, but you're still having treatment, what's normally, done to help manage that?
So again, if we're looking at a treatment, if the treating team says to you, we think this is the best course of action to cure this cancer, then it's weighing up those risks of the treatment versus the benefits of the treatment. So sometimes they will decide, well, we can change the dose. Instead of giving one big dose on day one, we can deliver that at a lower level over a few days. So again, it's very much a medical question, and talking to the treating team about the risks of the treatment versus the benefits of the treatment, and deciding whether any alterations can be made.
Someone's had immunotherapy and it triggered psoriasis, and so they have blockage of their ears quite a lot. So any suggestions for that?
Yeah, again, sometimes we do hear people, the skin in the ear canal gets really dry and irritated. And again, that's speaking to the doctors about whether there's ointment, whether there are drops, whether there are things that can be done to help manage that better. Yes.
Okay. Maybe one more, and then I know Tracey's sitting right next to you. We've got a couple of questions.
What I might do, Nadia, if I'll just introduce Tracey. So Tracey Nicholls has just joined us, an ENT nurse practitioner at Flinders Medical Centre, and someone who's worked with head and neck patients for many years, and will be coming to Tracey as well. But back to Nadia.
Thanks, Julie. So just one last question for you, Kathy. From Jerry in Queensland, wondering what is the best voice to text app on the market at the moment, either free or paid?
Yeah, I don't know exactly what would be considered the best. There actually are a lot of options these days. one of the things that I find quite easy on an iPhone is just using the notes. If you go into notes and click on the little microphone, you can talk and it will transcribe what you say. There is I did write down, there is a Google app that's meant to be very good as well, or you can just use the Google Word, whatever the Word program is, and you can use a microphone and speak into it. So they're something that you probably already have on your phone that you can use. There are a lot of paid ones that I don't really know what the benefits of the paid ones are, having a subscription.
And actually, Jerry has just put up a useful tip. Is everybody aware of the availability of real-time captioning if qualified under the NDIS for under 65-year-olds, as it increases community participation, and also are people aware that people can ask for captioners in hospitals in the public health system? So thank you for that, Jerry, and your captioner who's joined today. Tracey, we do have a couple of non-hearing related questions. One of them is from Carol, who's actually joining from New Zealand. What is the best sleeping position when you've had left side facial and neck surgery to prevent morning pain and stiffness?
Okay, thanks, Nadia. I think too, this is a very individual thing. It's about knowing why you've got, and anyone that's had major head and neck surgery, big neck dissection, I think you need to understand what's causing that. And it could be the disruption, obviously, to the musculature. Also, if there's any lymphedema present. My suggestion would be see a really good physiotherapist. They will give you a course and a range of exercise to do. There's different things, especially if it's a lymphedema type situation, that you could use low-level laser. There's acupuncture, even sleeping positions. Sometimes just that natural kind of having a wedge pillow so that you're draining from the head and neck area a little bit better. They're quite expensive, probably Australian dollars around $180, but even just putting things like bricks under the head of your bed so that your bed has actually got that natural draining slope as well. So in short, probably seeing a physiotherapist that could give you a range of exercise, undergoing some light level laser, and then using some different things in your sleeping position as well to help with that.
A couple of HPV related questions. One is about the recurrence. What's the likelihood of recurrence after being treated for an HPV related tonsil cancer? And another gentleman who has mentioned that his twin brother sadly passed away from throat cancer, and he's recently being diagnosed with a head and neck HPV related head and neck cancer, tonsil cancer. Any evidence that it could be genetic?
And I think that's the gold question as well. And I think, in particular with the HPV virus, and we all know that that evidence is changing rapidly, and detected early enough. There's detected early enough, treated with radiochemotherapy, and we're looking around, 80% cure rate. Cancer, is a very, in any individual, plays out a very different role in each of us. And I believe that it is genetic, environmental, and sometimes just bad luck. So I think, in particular, especially today, World Head and Neck Cancer Awareness Day, get it out there. If you notice any lumps, bumps, ulcers in your mouth that just won't go away, get them seen to very, very quickly. And if you're not happy with your, you've been to the GP, you still don't think after a course of antibiotics, nothing has changed, keep going till you find someone that's actually going to send you off to a specialist.
Could I just say, just before I throw to Nadia to close our proceedings, and thank you to all of you for staying with us, just for the totally new, the primary causes of head and neck cancers, or many head and neck cancers, in the past have predominantly been smoking, heavy drinking, or a combination of both. But in recent years, an increasing proportion of head and neck cancer patients, and I'm one of those, have our cancers caused by the human papillomavirus, and that is a sexually transmitted virus. And so there are really two groups now, and there are some, we've got a lot in common and we've got some differences, but I thought I'd just make that basic message, and just backing up what Tracey said about insisting your GP refer you to an ear, nose and throat doctor if you're concerned. Classic ones, you mentioned the ears, is of course an earache, a persistent earache, or two lumps on your neck, or a sore throat that just won't go away. There's more classic symptoms, and if you go to the Head and Neck Cancer Australia website, which I hope you'll do, you'll see a lot more information there about everything, fantastic diagrams, videos of patient stories, clinicians. But the more you can do, whether you're a patient, a family member, or a professional, to let people know about Head and Neck Cancer Australia's website and to share the information, the better. And I'll just say also, we will be sending everybody who's registered a survey so you can give us feedback. Our next webinar will be in September. And if you've got any questions that haven't been answered, 13 11 20 is Cancer Council's national free number, 13 11 20, information and support. But let me hand back now to our CEO, Nadia Rosen.
Thanks, Julie. And thank you very much, Julie, for hosting, and Kathy and Tracey for presenting and answering questions today. We had over 80 people registered to attend, and we wouldn't be able to do these webinars, obviously, without the expert professionals giving so generously of their time. And we know that they're beneficial not just for patients and carers. We've had a lot of healthcare professionals joining today, including a young woman who's just started her PhD in audiology. So we're really grateful for your time. And as Julie said, there are really two cohorts of people with head and neck cancer. The face of head and neck cancer has changed. And in addition to HPV, it's also young women who are being diagnosed with tongue cancers, and the reason for that is unknown. So we're still a very small charity, but we have pretty bold ambitions to make sure that people in the general public know the signs and symptoms of head and neck cancer, because the earlier they're diagnosed, the better their treatment options are. And we're hoping that it will be third time lucky. We're planning a parliamentary breakfast in Canberra. It was supposed to be on the 11th of August. Sadly, that won't happen because of COVID. We're hoping to hold that later in November. And what we're really aiming for is to advocate to raise awareness of head and neck cancer. Like other common cancers, receive funding to raise awareness of the signs and symptoms and to improve patient outcomes. So thank you for joining. Please continue following us on social media or sign up for our newsletter to keep up to date on what we're doing. And thank you for your support, and share our messages on World Head and Neck Cancer Day. Thanks very much, everyone. Bye-bye.
Thanks, Nadia.
Thank you.
Bye.